next few weeks have also joined, because I can tell you exactly what you can expect on the day of the exam. And I think that's something that many people don't really talk about or think of. And at least for me, it was just a case of going into this not really sure what to expect. All I knew was I had to come an hour before the exam and just eventually start the exam and finish in 2 hours. But I think hopefully once I'm done with this chat, it might help you calm your nerves, because you'd know what more to expect on like when to arrive, what to do in the next hour before you start. And also I'll share my results and feedback with you too, so that could be useful to look at. So starting off, we've already seen the PACES carousel. We all know what to expect. I'm not going to go into too much detail on how the stations work. But one thing to really consider and think of, if this is your first attempt, is that you have a 5 minute interval before each station. And I'll be honest, when I had my first attempt, I didn't really think too much about those 5 minutes. I just thought I'd have enough time to read through the scenario and then jump in. But what happens is, particularly with station number 3, which is cardio and neuro, you won't have a scenario to read. And also with the station 4, with the abdominal starting off. So you won't have a scenario to look at. You could just be um, relaxed, sitting there for 5 minutes. It'll be more of a break for you. Um, so starting off, you have to arrive at your given time. I'm sure some of you have already received your admission papers. You have to bring that with you, along with an identity card, anything that you can document your information. Uh, Funny story about this. So I had someone who was giving the exam in my center, and they came late to the center because they forgot to realize, they didn't actually notice that they had to attend or come to the outpatient center of the hospital, and instead they turned up to the hospital main gate and tried to figure out where the actual outpatient department was, when it was actually 10 minutes away from the actual hospital. So make sure you read your admission document and see where exactly you need to be, and double check that on Google Maps, because otherwise that'll just add to the stress. And I remember that poor chap came in around half an hour late, completely panicking. But of course, we had still had enough time to just sort of let him sit down and prep for the exam. So once you come in, the first thing you have to do is register. You sign your name into a whatever they have, their admitting sheet. And then you are sat down in a room with 4 other candidates. This is a nice time just to have a chat with the other 4, calm your nerves and speak to them about what they're expecting. Some of them might be giving it for the second time. So listen to what they have to say about how their first attempt went. And so this is the other bit that I didn't realize until I went in, is that when you're sitting in the waiting room and you still have an hour left, the reason why they actually call you in a full hour or so before the exam is because they have to hand you these clipboards with your mark sheets. And then you have to fill out those mark sheets with your candidate number, the examination number, and the center number. And you have to do that 16 times. And it's one of those sheets where you sort of circle, or sorry, draw over a box each time, like one of those OCR sheets, the old standard ones. So you have to do that 16 times on your mark sheet, and that actually takes a little over 20 minutes. And the interesting thing here is that's actually when they give you the clipboard, they'll tell you what station you're starting on, or the station you'll be starting on will be on the top. So I started with station number 3, and I knew that I will be starting with cardio and neuro. Also because the sheet itself will tell you that this is station 3 cardiovascular, station 3 neurology. So another thing to remember is you don't actually need to memorize which station number coincides with what station. It'll tell you on the mark sheet, and they will give you the mark sheet according to the order that you will do your exam. So I'm not really sure what's the best case scenario, whether the station starting on 3 or station starting on station 5. In my case, I started on station 3 on both attempts. So I thought it was good to get over with the tough parts first. And you also have the lead organizer come in near the end of the 1 hour just to welcome you and just tell you some nice soothing words about how everything in the exam is what you prepared for. Nothing's coming out of what you've been told to prepare. And that also, I think, helps calm your nerves. So now I'll just go into the actual stations I had. I started off with station 3 cardiology, and I had this prompt, and I'll just start listing the findings in the same chronological order of my examination. So on inspection, I noticed this lady had a midline sternotomy scar, and there was also a small scar in the left intraclavicular area. And I didn't notice any signs of cyanosis or clubbing or any features of infective endocarditis. And that already gave me an idea of what to expect with the station. Moving on with the examination part, the pulse was regular. It was not collapsing. JVP was normal. There was no pallor or central cyanosis. And then I'll come to the heart sounds in a second, but just to let you know, the back and legs just showed some mild pitting edema to the mid shins. Now, this is what I found with the auscultation. So I usually start off with the aortic area first, just because I'm a creature of habit. I like to do it the same way each time. So I started out with the aortic area and I heard a moderate systolic murmur. Then I listened to the pulmonic area and I didn't hear any murmurs. Similarly, going down, no murmur there. And I thought there was a very mild systolic murmur at the apex as well. And then I went on to listen to the radiations and I actually heard some radiation going towards the carotid. So that was really the giveaway. There was no radiation in the axilla. One thing here that I remembered during the exam was that sometimes with aortic AS murmurs, you can hear the murmur even down to the apex, but it's not actually mitral, it's not really a mitral egress murmur, it's more likely to be an AS murmur because you've also got radiation going to the carotids. And of course, now here's the tricky part. You finish cardiology station, you've spoken to the examiner, you've given your presentation, they've asked you the questions, and you hear a knock outside the door. That knock is actually the end of your 6 minutes of cardiology and the beginning of your next 6 minutes with neurology. So unfortunately, you're already, since as soon as they give you the knock, you're losing time for your neurology station. And that means you still have to walk with the examiners, depending on what sort of room they have or what setup they have. You'll have to walk out that door, go into another room, enter that room, look at the prompt for neurology, and then examine the patient. And I honestly think that takes around 20 seconds out of your 6 minute. So just be wary of that and expect that when you're going in. So maybe just try and nail your neuro exams in 5 minutes and 30 seconds. So this is what I had in my neurology prompt, that there was a man with double vision, and I was asked to examine the cranial nerves. Cranial nerve 1 was normal. Again, nothing on cranial nerve 2 or the optic nerve. Then cranial nerve 3, 4, 6, when I was doing the haste test for the oculomotor, the patient mentioned, he literally told me that he's got some double vision when he's looking to the left, which is worse when looking down and left. And then after that, all the other cranial nerves were normal. And because that's the only finding I had in the whole cranial nerve exam, I had a lot of time left even after I finished. So I just went back to test the eyes again. And I asked about pain. And I even checked for any scars on the head for any surgeries. And just to note, when I was asking about pain, I just asked when he was moving his eyes whether there was pain there, because you can't actually ask too many questions apart from just like, in this case, just the one question here about pain or double vision. Um, just from this, can anyone give up some guesses as to what the diagnosis could be? Oh, I don't know how to look at the chat itself. One second. Oh, oh, anyone, any diagnosis at all for this? I guess not. That's okay. Going back to the slideshow though. Oculomotor abducens nerve palsy. That's the left abducens nerve. So those were my guesses too, and I said, okay, so it's something with the eyes. It might be oculomotor, it might be abducens. Uh, so what it actually was a trochlear nerve palsy, and I was rubbish in any of the eye palsies whatsoever, because Um, all I knew was that I could try and figure out where they've got double vision and then try to work out if it's one side, if it's abducens or trochlear. The one hint that they were giving me was that it was worse when they were looking left and down. This is what I got in my feedback, and it says clearly that I did not test the eyes separately, and I also did not offer fundoscopy because I was panicking. Um, and they felt that my assessment for eye movements was very cursory, and I did not really define the area of diplopia. So what this feedback is showing me, that I actually got 0 marks for physical examination here, and 0 marks for identifying physical signs, because I also missed out the restricted adduction of the left eye. Um, So what you're supposed to do with cranial nerves, at least with the oculomotor, trochlear, or abducens nerve palsies, is also examine or test the eye separately. This is not something that I was used to doing in my practice for BACES, and didn't even know that I need to test the eye separately. So when I was presenting my case, I just said this could be oculomotor, trochlear, or obtusans, and they tried to just push me towards diagnosis. And I eventually went to say that it's likely going to be abducens or trochlear, because there's no pain, and also the I think the light reflex was normal. So it's quite difficult. This station was. Moving on to the next, station 4. This was a communication station. I'll just give you a minute to actually read what was on the prompt. So essentially, it was about someone who's had a new diagnosis of GBS. And thankfully, they told me the diagnosis was GBS, and all I was supposed to do is explain the diagnosis to the patient, include the next steps in management, and address their concerns. So I tend to follow the spikes protocol. You might have a different protocol in your head, but just make sure that you have a protocol in mind, just so you don't end up missing things. So after I explained the diagnosis as best I could, the patient had some questions, and basically it was about whether it could be multiple sclerosis. Will he get better? Could he go home after the IVIG? Now, you could imagine the first question and the second question is probably easy to answer, which is no and yes. But going home after the IVIG, I wasn't entirely sure what the timeline is for or the course of diseases for someone with GBS. So I wasn't very confident in saying that, oh, it's going to be days or weeks or months. So instead, I just said something like, we'll just start you on the IVIG and see how you go. You've got a neurology unit over there, and I'm sure the doctors there will just keep an eye on your recovery. And because of that, I got a borderline, sorry, borderline result for communications because I couldn't give clear information about the course of the disease. And then for clinical judgment, again, I got borderline because I forgot to mention the need for assessing vital capacity. In my head, I thought it might be for someone who's very symptomatic. But I think, again, in GBS, once you've got a case of GBS, it's important to mention that it can also affect your lungs, and therefore we need to monitor the vital capacity. And then this was the abdominal station here. The gentleman presents with tiredness. Please perform an abdominal exam. So this is the first thing that I saw in the abdominal station was this guy had a stoma. And when I looked inside the stoma, I think what I saw was type 6 stool. Of course, remember to have a look inside the stoma to see your contents and just look around the stoma for any inflammation and just have a system to how you examine a stoma bag too. There was I think there were a couple scars that I saw. One was a midline laparotomy and another one just next to it. So presumably he's had multiple abdominal surgeries. And then I also saw a right diagonal inguinal scar, which I'm sure you all would know could actually make this into a kidney or a renal station. But I wasn't sure entirely because in my head, I thought it could also just be the lining of his trousers making that scar on him because it was just really that low. So I thought I'll just skip it for now. Um, Moving on to the arms and neck, there was nothing there, no fistulas, no lines. And then in the abdomen, no signs either, no organomegaly. And I double checked for any masses underneath the scar. There was nothing there. And I got the 1 minute warning before I got to assessing ascites. And I think personally, I think I didn't finish that station soon enough. Mainly because I felt when I've been practicing for the abdominal station and PACES, I got more and more comfortable with catching renal pathologies, and I didn't spend too much time on things like IVD or what to say when someone's got a stoma, basically. And that's why I got the feedback that I didn't complete the examination here. This was actually a case of Crohn's disease, and the interesting thing about this station was that when they asked me to present the case, I told them my positive findings and I told them my differentials. Instead of going down the route of Crohn's disease or IBD, they took it to a different route and said, how would you manage this case of someone presenting with a high output stoma? And then they asked me about the electrolyte disturbances that are commonly seen in high output stomas. And again, even though I was able to give the answers, it was still not quite what I was expecting. I thought it would just usually be about IBD itself and the management of IBD, but in this case, it wasn't. So apparently that can also happen on a PACES exam. Then this was my 20-minute consultation, the first one that I had. So I'll let you read this. 85-year-old gentleman presenting with weight loss and loss of appetite in the last 6 months. Review the patient and address his concerns, outlining the next steps in management. Now, if you were there in my position and you read this in the prompt, what sort of differentials would you consider? Could anyone try and give us some differentials? Malignancy, exactly. So as soon as I read the words weight loss, loss of appetite, 6 month, 85-year-old, I just immediately went malignancy. And that's the only thing that my head was buzzing with. And I thought this should be an easy scenario where I just ask them questions about their weight and their appetite and family history, that sort of stuff. Yeah, so let's see what happened. So you have 20 minutes, and again, that's a lot of time, 20 minutes. I had more than enough time left even at the end of my consultation station. So history presenting complaints, there was nothing interesting. On past medical history, this guy had rheumatoid arthritis and high blood pressure. Medications included rituximab, and he mentioned that he's previously been on methotrexate, but he was switched to rituximab now. And then in the family history, lo and behold, he mentions that his mum died from some kind of cancer. Social history, he was an ex-smoker, doesn't drink alcohol, nothing special about his occupation. And then on examination, as I expected, I saw some ulnar deviation, so some metacarpophalangeal joint swelling. Lymph nodes were normal, eyes were okay. I heard some crackles on the right side of his chest. And that's all the information I had to go on for him. And then when I talked to him about um, his findings, his first question was, could this be cancer? And the way that I'm sure that you all know how to deal with a possible cancer diagnosis in PACES is that you can't say no, but you also can't say definitely yes. So you talk about the investigation that this person might need before we confirm this. And so yeah, the usual bits, blood tests, imaging, and then MDT, and then we'll get back to him to confirm what this could be. Um, this is what I got from my feedback for this station. Now, I got a borderline for identifying physical signs. Because apparently I thought the crackers were right-sided, but apparently this examiner said it was clearly bilateral. To me, it wasn't, but apparently it was. So that can happen sometimes in the exam where you end up just listening. And so obviously you can only tell them what you hear. And then in clinical communication skills, this was the very annoying part, which I still hate myself for doing this, is that I forgot to ask about infective symptoms. Now, like you guys mentioned, that this was probably more likely a malignancy case. I had the same thing in mind as well. So I never, for some reason, never really got to talking about infective symptoms or asking him about any symptom of infection. Maybe it's because when I was there, I was thinking a lot more on the sorry, thinking a lot more about the malignancy rather than trying to rule out other things. And that's why I think with consultations, what's really important and this is what I got right the second time round is that I had a cluster of questions in my head for each system. And I also had a cluster of questions in my head for some of the main presenting findings. So you could maybe just sit down one day and just make some questions on a list and just go through them, make sure that you don't miss anything. I think this part, making a cluster of questions in your head was probably the one thing that actually helped me pass the second time round. And communication stations, you're a resident doctor at the general medical ward. I let you read this for a minute. If you have any questions in the middle, just raise your hand and I can always take the questions in the middle. Don't mind. Yeah, so from what I remember, I think this was basically a lady. Was it about a lady? The wife, right? Yeah. The wife on the ward wants to talk to you because she feels that her husband shouldn't be ready to come home yet. Now, just reading the prompt here, I don't think it's very clear why the wife isn't happy. When I was reading the prompt, I thought, oh, maybe it's the fact that we've not given her a medical update. So when I went into it thinking I just need to uh give his wife a update about him, and then she should be fine. But things were actually slightly different. So as I went in, the first thing she told me was that she couldn't believe that he's coming home, and she was surprised that it's only been a couple of days. How come he's well enough already? And then she started getting more and more emotional and started practically begging me to keep him in the hospital for a few more weeks. So this is how my station started. So I thought, okay, let's try and get some background on why she's actually so worried about this. And when I did ask her about her husband, this is when she mentions that my husband has Alzheimer's for so many years. And that was the first um, spark in my head that, could it be the fact that she's not being able to take care of him at home? And it was that case. So essentially, it was just her complaining that she needs some help at home. And then from that point on, you can imagine it was quite straightforward, where you'll talk about having occupational therapy and physiotherapy and making sure that he's got carers at home and whatever help they need. So yeah, I think the communication stations on both my exam were very straightforward. And then there was the respiratory station, someone presenting with shortness of breath. So on inspection, I didn't find anything on bedside, usually looking for inhalers and that kind of stuff. I noticed some clear clubbings on the hands, and the patient was very cachectic, clearly. And I didn't find any scars around their chest, front or back. Arms, face, and neck, nothing exciting. And when I went to the back, this is what I found. So bilateral cleft at bases, which I thought were on inspiration, and they were coarse. I've highlighted coarse with the red because on the day of the exam, I wasn't sure if they were coarse or fine. Now, all of us have done lots of chest auscultations in the past, and we all probably know what the difference is. But sometimes when it's kind of in the middle and you're in your exam, you're just sometimes not sure. And when I listened to the front, again, there were some crackles at the bases, but they were less audible. And there was no edema. So this was a station that I think I messed up on because of my own shortcomings. Um, Identifying physical signs. I got a borderline mark here because I missed the decreased percussion note. So you're probably thinking that you don't actually need to be very good at understanding percussion notes to diagnose a patient. But clearly, as you can see, you still need to be able to identify that physical sign. You might still get the right diagnosis without catching the percussion note, but again, you still get points for physical signs. And if you've missed that in your presentation, then you do lose a mark for that, unfortunately. And in the differentials for this one, I completely messed up and I said this is very likely going to be COPD, even though the patient had clubbing. I have no clue what I was thinking. Maybe I was thinking about the last station or how I messed up neurology or something. But I got the differentials very wrong, and I got 0 marks for the differential diagnosis, and therefore 0 marks for the clinical judgment as well. Any questions so far? I think I'm rushing into this. You can either raise your hand or just leave a message on the chat. I'll give you maybe 10 seconds. Hmm. What was the diagnosis? ILD, clubbing. Yeah, should be straightforward to catch. So I think the reason I messed up is because I thought it was coarse crackles, whereas seems like it was fine instead. Do you usually get this feedback? So when you get your results, sorry, I'm just going to pause in the middle and talk about feedback now for a few seconds. When you, no clubbing, right? Yeah, I think maybe I messed up on saying that there was clubbing when in fact there wasn't any clubbing. I apologize. It's been a little while. So I mentioned clubbing where although the patients didn't have clubbing. So that's how brilliantly I messed up. Um, and even though I mentioned clubbing, I still went with COPD, which makes no sense. So I messed that station pretty much the whole station, which is bad. Going back to the question about feedback, Majid, when you get your results, you can always email so I don't know if you're applying through RCP London or Edinburgh, wherever, you email them back to say that you're requesting feedback. And I think they also have it on the website for MRCP PACES where you can ask for feedback. And I think they're quite useful. Just remember on the day of the exam, you have two examiners. So you have two feedback forms each for each station. Thank you. Moving on to, I think this was my last station. Yeah, station 5 was the consultation. 60-year-old man presenting with progressive shortness of breath in the last few months. We would be grateful if you could review him. So, um, what do you guys think? Any differentials before we begin? You've read this outside the room. What could you think of just based on the prompt? Heart failure, COPD, congestive cardiac failure, respiratory causes, anemia. Yeah, so exactly. So you're right. Pretty much I had those bells ringing in my head too. So when I went in and I took some history, he mentioned that he was short of breath on exertion, but not on lying flat. That helps you rule out heart failure, possibly. Past medical history, nothing significant. Medication history, nothing. Again, this guy's mom died from some cancer again. And social history, nothing exciting. And this is my station. So the only positive examination finding I had was a murmur that was heard loudest in the apex, radiating through the axilla. And obviously this made me think of mitral regurg. And so these were the questions that this guy had for me. So first of all, it was, what's wrong with me? So you tell them that, oh, you've got a leaky valve, blah, blah, blah. Could your wife have it? Again, it's unlikely that you can catch it from someone else, but you, I think what I did was I asked him about her symptoms and then he wasn't sure, so I moved on to another question. He asked about the possibility of surgery, and obviously I talked about having an echocardiogram first and then going on to possibility of surgery. Um, so okay, again, pre-anesthetic fitness and all those things are important here. And then he mentions there was this very specific question that his friend had a surgery for his liver through a keyhole. Could his also be done that way? Um, Again, I think I said that if we could think about this possibly, because if it's laparoscopic, we're not expecting this one to be an open heart surgery either. And then, can you still drink with your mates? Probably not. Avoid alcohol at all costs. This was the feedback that I got for this station. Now, yeah, so again, in this one, because I think my mistake was that as soon as I did my examination findings and I found the murmur and I knew what this was, I didn't go back to ask him some further questions, some leading questions, such as palpitations. And as a result, I missed the fact that he has paroxysmal atrial fibrillation. So this was actually also one of the diagnoses that this gentleman had. And therefore, because I missed paroxysmal AF, I also lost a mark in clinical judgment because I couldn't tell them much about what to do with AF. So it's again very important to have a cluster of questions in your head. If someone told me that the first time round, I probably would have passed my exam. Um, so I prepared for it the right way with all the clusters in my head the second time, and I managed to pass it. So again, clusters. Did someone leave a message? Didn't they say it when you asked about past medical history? So, oh, good point, Aruj. So I was complaining about the exact same thing to everyone after my exam. I asked the guy in for your past medical history, do you have any heart conditions? And he says, no. And I mentioned anything else? Have you got any problems with your lungs, blah, blah, blah. So the usual way I question is, do you have any medical conditions? Anything related to your heart or your lungs or diabetes or high blood pressure? He said, no, 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 no. Um, I didn't specifically ask about palpitations. I didn't specifically ask about a racing heart. And therefore, he didn't mention paroxysmal atrial fibrillation to me. And this is what happens. Funnily enough, I know it sounds quite unfair. On my second exam, I promise you, I had a similar case, not similar. It was a guy who collapsed and he came in and we were in the GP service. And in the second exam, the same thing happened where I asked about his medical history, and he said, "Oh, he's got no problems apart from some high blood pressure." And then I said, "Have you noticed that you've got a racing heart, or sometimes do you feel like your heart's beating a lot faster?" And then he said, "Oh yeah, that happens to me a couple times occasionally." And then you realize, that's paroxysmal AF. And in which center was this? So this first one, the one that you're looking at now, this was at Ashington, which is near Newcastle. Um, I'll be honest, the exam itself was actually quite easy looking back. I think we got some really easy cases in that center over there in Newcastle. But it was just these minute things that were somehow the make it or break it. And unfortunately, that does happen. Were you able to take any notes in with you for the consultation stations? Yes. So for all my consultation stations, I would first of all write down the setting. So when I say the setting, I mean like where am I as the doctor? Am I in the admissions unit? Am I in an outpatients department? Am I in A&E, just to help me understand what the setting is? And then I write down the age of the patient. I write down their presenting complaint, some differentials. Then I quickly write down some questions to ask. And yes, you can take that paper with you. And I was looking at the paper a lot of times in both my exams, and nobody marked me out for that. So use your paper as much as you like. No one's going to stop you. Basically, become a talking systems questionnaire instead of a human doctor. Yeah, so the thing is, if you, again, and I'll be honest, if you have that cluster of questions in your head, you will remember to ask them to the patient. If you don't have a cluster and you just go by your gut feeling because you think, oh, I know exactly what to ask about chest pain. I've been doing this for the last 4 years. And then just because you forgot to ask about the racing heart, suddenly you lose like 3 or 4 marks in your station. And then that could sometimes be a pass or the difference between a pass or a fail. Um, and did I tell you this? Yeah, I talked about this already tonight. So that was the whole exam. I'm not done yet. I need to also show you my results sheet in a second so you can make a sense of how the domains are individually marked. But before I get to that, this is what I did not expect. First thing is the fact that you will lose 15 seconds or 20 seconds, particularly with the cardio neuro switch. So be prepared. Make sure that you're finishing your neuro exam within 5 minutes, 30 seconds. Make sure you're finishing a normal neuro exam within 5 minutes. Just be absolutely sure that you are not getting 6 minutes in your neuro exam whatsoever. And in my communication stations for both exams, because I had two communication stations each, in all four comm stations, I was finishing well early. Sometimes I was finishing 30, 40 seconds early, and I got full marks for my comms. Someone's writing something. Does the switch happen at 6 or 10? Sorry, I apologize. It does happen at 10. So when you finish the presentation and the examiner finishes asking the questions, and then you're asked to move on to the next station, that's when the clock for the neuro station begins. For the examination station, do you get a reminder or a bell when 6 minutes are up? So you get a reminder or a bell at 5 minutes, letting you know that there's 1 minute left. And then when the 6 minutes are up, the examiners will stop you there and say that, okay, your 6 minutes are up. Can you now present your case? Does that make sense, Safia? Yeah, yeah. And then third point that I did not expect was the order of questioning not having a set pattern. And I say that because, especially with my abdominal station, I was expecting them to ask me about Crohn's disease and, the investigations, the management, blah, 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 steroids, azathioprine or whatever. But instead they took me to a different line of questioning about electrolyte disturbances in high output stomas and diarrhea. So that can also sometimes happen, although I don't think it massively shocks you. But yeah, can happen. And yeah, sometimes you can forget stuff. So I completely just made up the finding of clubbing in the respiratory exam. In another station, I thought it was unilateral crackles when in fact they were bilateral crackles, and that happens. You just have to make sure that you don't make things up. That's one thing. Second advice I can give to you is make sure you have a cluster of questions in your head for the consultation stations. And what else can I tell you? Make sure that you finish your neuro stations early, 5 minutes and 30 seconds, please. And yeah, just remember you do have a piece of paper to write down stuff on for the consultation specifically. Well, you have them for all stations, but I think they're useful in the consultations. I'm just going to quickly show you the results sheet that I get. 1 minute, please. MRCP exam. There we are. Where am I going with this? There. No. Oh, here. Cool. How big is it's just how big is the paper, and is there a clipboard? You get a pen or a pencil. You get a pencil and it's an A4 sized paper. It's plain with no lines. You don't get a clipboard, unfortunately, because you have a clipboard with your mark sheets that you then hand over to the examiner for each station. So you just get a piece of paper lying around and just a pencil next to it. You write stuff down. I don't think it has an eraser with it. You also get a cup of, or whatever, glass of water next to the in the 5 minute breaks that you have in the tables there. Results. Let's look at the results. Okay, so this is it. This is the one that tells me that I failed, I think. We are sorry to inform you that you have been unsuccessful. Boo-hoo. So this was it. I'm going to try and explain how you get marked. Whoops, sorry. No, I'm going to zoom out a bit. Sorry. Yeah, that's good enough. Hopefully you can all see this right. Can you? Yeah, I think you can. Right. So if you can look at the top half gives you the marks that you get for each station, right? So for communication 1, I get 16 out of 16. For respiratory, I mess it up and I get 12 out of 20 for consultations. So that's how you get marks on for the stations. But the actual marking is here because you get marked according to each skill or each domain, and you have to pass each domain. Now, if you look at all the way here on the right-hand side, the total score required is 126. What did I get? 130. So I thought I passed, but actually, if you go down all the way here to clinical communications, I got a total score of 10 out of 16, and the pass mark was 11. And so I failed clinical communications, and hence I failed the whole exam. So that's how you get marked for PACES. In my second attempt, I got a bit more than 126. Sorry, a bit more than 130. I got 135, and hence that was good enough. Yeah, you're right. So I'm sure you've looked at the mark sheets for each individual station. Not every domain is marked on across all of the stations that you get. I can't remember which ones, but I think like Uruj mentioned, clinical comms is not marked on the examinations because again, you're not really communicating with the patient. And even if you felt you did not do well on the exams, it was actually the consultations and comms that brought you down. Exactly. So on my first attempt, I thought I messed up the respiratory and the neuro exam and I'm going to fail. When I got the result, I thought, 130, that's above the passing mark. I didn't get enough marks on my consultation stations, even though I thought I did pretty good. But what I realized with consultations was I didn't have a structured cluster of questions to ask and blurt out to every patient. I think having a cluster I think it also helps because then you've made sure that you've got all the information from the patient. And also you probably noticed that one domain is also kind of linked to the other domain too. So if you're not really getting the diagnosis right, then you can't get the clinical judgment part right. And that means that you're losing points in more than one domain because you made one mistake.